dependent regarding the liver biopsy. But being a pediatric hepatologist, over these years, we have been quite dependent on liver biopsies, and they have been very helpful in deciding what kind of diagnosis and decision making should be there. So today's talk is about pre-transplant evaluation and optimization for a child who needs liver transplant. So when we talk of pediatric liver transplant, first thing that comes to our mind that we should have a good setup for a successful transplant program, and that should include a lot of people in it, which includes so the transplant surgeon, the most important person in the house, and then the pediatric hepatologist, pediatric surgeons. We find that pediatric surgeons are not really the part of the transplant program as such, but I would really want the pediatric surgeons to be the leading persons for the pediatric transplant programs. Most of the times, the transplant surgeons are specialized in doing the pediatric transplants also, but if the presence of pediatric surgeon would be a real good add-on to the program. Then infectious disease persons should be there, and the critical PICU team guy should be there, and social worker is very important person to handle the parents and the issues related to that, psychologist, neurologist, and a number of other people. So trained team of even the nursing team is a very big core thing that should be there in the team. And other than that, the psychiatrists, the transplant coordinators, so a very experienced anesthesiologist should be there. So with a whole all of these being in the team, that can give us an excellent result. So the pearls of pre-transplant assessment, I would say, would be, first of all, when the patient is sent to us, get the whole data of the patient. That includes the history, the examination, the previous surgeries, previous presenting symptoms the child had, and what all treatment has been done till now. Then you should be taking into consideration why the patient has been referred to us. Does the patient actually require transplant or not? Most of the times we are referred many patients of jaundice, which turn out to be treatable by medicines only, and they don't really need a transplant. So just once the patient comes to us, we try to establish a diagnosis, come to a conclusion whether really needs a transplant, or without transplant the things can go on. And then we should see what the diagnosis is. What is the severity of the diagnosis? What is the kind of treatment that can be offered? And yes, again, the same thing that if possible, we would like to treat the child medically as far as possible, and transplant be the last option when there is no other way the child can be saved. Then we see, once we have decided that the patient needs a transplant, then we look forward to seeing if there is any kind of a contraindication, although there are hardly any contraindication in nowadays, but a child who is having severe neurological problems, whose survival or neurological improvement after transplant is not going to improve much, then I would say we should not be going ahead, especially in those who have got severe neurological damage. In those children, transplant is, I would say, kind of a contraindication. Other relative contraindications which would settle down over time if we have a good transplant team would be like severe sepsis, severe infections, and others. Encephalopathy grade 3 and 4, once the patient goes into 3, 4 in progression, is that it goes beyond that, then it becomes kind of a contraindication. And then we should be looking to if we have seen that there is no contraindication towards the transplant, then we should go ahead and see who would be the appropriate donor. In our country, most of the times in North India, especially, we are doing the living donor transplants, and we would want to counsel the parents how they would want it. We would give them the option of the DDLT as well as the LDLT, and depending on the condition of the child, whether it's that the child can hold on till the disease donor is found, or if there is an urgency, we would want to go ahead and do a living donor transplant, and then we would go ahead and assess the donor most of the times it's the parents that are the donors, and we would go ahead in that direction. Once the donor is confirmed, then we start with the donor workup, and along with that, we'll also look into the immunization status of the child. And if the patient is completely immunized, that's good. But if it is not completely immunized for age, then we would quickly go into immunizations and try to give the whatever best possible immunization that we can give for that age. Preferably, we would give immunization for, we would avoid giving live vaccines if the transplant is planned within a month. So you can give live vaccines when you are thinking that the child will be transplanted after 1 month. And you can give other inactivated vaccines or killed vaccines 2 weeks before the transplant. So, and then comes the issue of the parents. Once we counsel them, now we've seen that the child needs a transplant, we have seen the donor. In between that, we counsel what is transplant, how we would go ahead. A relationship develops between the parents and us, and as well as the child, and that should go in the positive direction. Then we also talk about the finances. We see how we can arrange for them. If they are not able to do, we have NGOs supporting us. We have the crowdfunding thing that is supporting us. So in that part also, we try to fund them. And once all the finances, donor workups are done, then we go ahead with the committee clearance. Once we get the committee clearance, we can go ahead with the transplants. And during this all counseling, we do tell them about the chances of survival depending upon the kind of diagnosis the child has, and later on, how the things will go post-transplant. All the issues are discussed pre-transplant. Now, the most important part of the transplant program is the timely referral. The timely referral is very much an indication how the transplant will go. Especially the urgent referrals should be done in cases of acute liver failure and those who decompensate very fast. They should be referred very quickly. And the patients of MLD like MSUD and urea cycle defects and other sorts of metabolic liver disorders, which are not getting better with the dietary management or the dietary, even after the dietary management, their levels of the ammonia or is very high, or neurological symptoms are persisting, or the hypoglycemias are happening. Before these issues affect the brain severely, they should be transplanted. So in these cases in which the dietary management is not getting successful, then these cases also should be urgently sent for transplant. Those other category would be unresectable hepatoblastomas, HCC, who have not actually had metastasis. They should also be urgently referred for a transplant. In cases of biliary atresia, if there is, as you know, bilirubin not coming down below 6 over next 3 months of post-Kasai phase, these children should be considered for transplant. And even in those in which post-Kasai, the bilirubin level is between 2 to 6 and is not coming down below that for a long time, they should at least be started on transplant workup so that even if they need a transplant later on, things are ready for them. Once the child gets to us, the most important, as a pathologist, the managing part, if we see, we get ascites as the major part. So managing pre-transplant ascites is one of the bigger challenges once we see the pre-transplant issues, pre-transplant phase. And for that, most of the times spironolactone works well. But if the abdominal distension is too much and it is hindering the respiratory pattern of the child, then we would do a paracentesis along with albumin infusion, and very rarely tips would be required to handle the severe ascites. We should always counsel the parents about the presence. If the diagnosis of AIH or PSC is there, then the parents should be told that this diagnosis might reoccur after the transplant. There are good enough chances that autoimmune hepatitis and primary sclerosing cholangitis might reoccur after transplant. This should come into the counseling. So, And also these kids, the parents of these kids should be told that the colonoscopy, screening colonoscopy needs to be done because IBD is an issue in these cases. And long-term repeated colonoscopy might be required to prevent uh, further complications as cancers. So surveillance is required post-transplant also, and long-term issues can be there in these cases, so proper counseling should be done in these cases. As far as encephalopathy is concerned, all has been discussed by Dr. Neelam. I would not go into that. Close monitoring should be done, 3% saline mannitol, and other general care should be taken care of in these cases. Now coming to the nutritional assessment, this is one of the most important part of the pre-transplant assessment and optimization. Once we have a child, usually is malnourished because the child has malabsorption and has a hypermetabolic state, and that leads to increased requirement of calories. And in these kids, you would find the calorie requirement going from 20% to 80% more than the normal child's RDA requirement. So we should target good calories in these children. And when we assess the patients for malnutrition, we usually take care of the weight and the height, but the better markers are the triceps skin fold and the mid-arm circumference. They are better markers for the actual malnutrition state of these kids rather than the weight of the child, because weight of the child can be affected by the ascites and it will not give you the dry weight. So that would not give you, the proper assessment will not happen. So always look for the triceps skin fold and mid-arm circumference for the nutritional status of the child. And then, as I said, aggressive management should be started as soon as possible whenever the patient comes to us for transplant. The first thing that we would look for is to somehow improving the nutritional status of the child, because that determines the post-op results also. Other than the only the calories, we should also give the fat-soluble vitamins supplements. They should be given at a higher dose, and the MCT containing supplements should be used because these are much easily absorbed. And if the child does not have encephalopathy or ammonia is not raised, you can still give a good amount of proteins to normal as 2 to 4 grams per kg and keep the child under monitoring. And if after all this supplementation in calories and the nutrition, the child doesn't improve, then we might need to even admit the child and give NG tube feeding so that we can optimize the child and at least increase the weight and make the child better nutritionally so that we can have good results. So once we have a child, we would start with the normal feeding and we would target at least 130% of the RDA. I would say we would start increasing it slowly. If the child tolerates it, well and good. We'll keep a monitoring on the child, keep the checking the anthropometry regularly over 2 to 4 weeks. And if the child doesn't improve, and if the child is in this group in which the infants are there, and the child is on breastfeeding, we would add the breast milk fortifiers to increase the calories and use the MCT-rich formulas where the child is on formula feeding. And we would increase the number of feed, ask the mother to have extra effort in the feeding. We would try to increase the number of feeds if possible and keep a close watch on the anthropometry. On the other side, if the child is older, we would again increase the portion sizes of the food that we are giving, and also add on to the bedtime snacks. And we would target the formulas to be 1 to 1.5 ml per kilocalorie per ml energy in that. That would increase the total calorie intake for the child and keep a close watch on the anthropometry. Now this is the second step. Even after this, if things don't improve, then as I said, we would like to admit and start with the NG feed if that could be of help. And we can increase the portion of this email MC2 to even 50 to even more to 80% of the total fat that can be given to the child. And avoid hypoglycemias. I keep a close watch on the child. And we can use bolus feeding every 2 hourly, or if things still don't improve, then you can go on to continuous feeding. And during this NG feeding, we should always continue with the oral feeding. We should not stop the oral feeding. We should promote the oral feeding, and slowly, we hope that the child improves on his way, the total anthropometric parameters. And at the end, we would, if still the things are not okay, then we would take help of parental nutrition. But usually, what we have seen is that optimizing the child, no matter how much you try before the transplant, the child will not come to its normal anthropometry. It usually is that optimization happens post-transplant only. Once the transplant happens, then the child grows well. Now, looking after the dietary issues, there are many patients who have cardiac issues along with the chronic liver disease that they are having. And the cases like biliary atresia and Alagille syndrome, you can find structural heart diseases in them. And there are cases in which cardiomyopathy can happen, like in cirrhosis itself can lead to cardiomyopathy. Other metabolic liver disorders like GSD can have cardiomyopathy in them, and mitochondrial disorders can have cardiomyopathy in them. So we should know that it's that not that only the liver would be involved, it is out of the liver, other systems can be involved, and heart could be one of the organs that could be having issues. So we should not neglect that part. We should always do a cardiac assessment by a pediatric cardiologist, and an echo should be done, and we should always assess these issues. Another thing that we face is the hepatopulmonary syndrome in children, which is not so common, and also the portopulmonary hypertension that can happen, which is also very rare. But these are things that we should know, and these should be suspected in children who have cyanosis and can have clubbing and facial telangiectasia, have wheezing, dyspnea. In these kids, there is a likelihood that their child would be having HPS, and we should always check the oxygen saturation. Not for that matter, only in these kids, we should see in all the kids the saturation should be seen. And if it is less than 97%, we should do a bubble echo to see the perfusion. Lung perfusion, vasodilation can be seen, the bubbles can be seen, and the contrast echo should be done in these cases. And we can also do the MMA in these cases. For the diagnosis of portopulmonary hypertension, the X-ray can give you a picture. The X-ray will show you end-on arteries getting increased, and the ECG will show you right ventricular hypertrophy. And in these cases, you might need a cardiac catheterization to diagnose that. The treatment for HPS and portopulmonary hypertension, usually for HPS is giving oxygen, but without a transplant, things won't revert. So for both of them, transplant would be the modality of treatment. In cases of cystic fibrosis, you can have pulmonary issues. They can have recurrent pulmonary infections, and other pulmonary problems. For that, you can do FEV1, FCV, pulmonary functions can be done, but these kids are too small to undergo FEV1 or FVC. Now, coming to the next organ is the renal assessment. For renal assessment, we should know that, again, as I said, for the cardiac issues, these children who are having liver problems can also have comorbidities in the kidney. In cases of tyrosinemia, you can have primary hyperoxaluria can have kidney issues, and congenital hepatic fibrosis. MMA can have, as well as alpha-1 antitrypsin deficiency patients can have. Alagille also shows kidney problems. And for that matter, even tacrolimus, which will be given after the transplant, that can hit the kidney and can cause kidney issues. So screening of the kidney is again one of the major, it is a major part of pre-transplant assessment in a child who needs a transplant. So how do we do the renal assessment? Usually urea creatinine are the primary markers, but creatinine has its own problems, like it is affected by the muscle mass, it is affected by the age, it is affected by the gender, and the renal tubular absorption and secretion can happen with creatinine. So creatinine would not be the choice. A better choice would be revised Schwartz formula, and even better would be cystatin C, because cystatin C is a low molecular weight protein. It is almost completely filtered into the glomerulus. It is not absorbed or secreted through the tubules, and it's not affected by the mass or the age or the gender. So best marker as far as kidney screening is cystatin C, but usually we are more dependent on the creatinine levels. And there is one more pediatric modified rifle scoring that can tell us things. It also includes not only the creatinine clearance, it also includes the urine output. And there are 5 categories to it: R, I, F, L, and E. So risk to injury, injury to the kidney, failure of the kidney, and loss of function of the kidneys, and the end-stage kidney disorder. So this is one of the criteria which is used in patients who are having acute kidney problems. So seeing all these kidney issues is very important, and screening for kidney problems is an important part of the assessment for pre-transplant workup. Again, dental issues can be there in children. You might see children having flat teeth, having dental caries, gingival diseases, dental abscesses. These sometimes becomes a contraindication or delay in the, not a contraindication, but a delay in the transplant before, because these issues can cause sepsis post-transplant, because once the immunosuppression is started, these sites can flare up and cause systemic infections if the infection is there in and around the gingiva or the teeth. So these should be managed, and screening should be done by the dentist before the transplant. Again, most important part, anesthesia, PAC. Obviously, these children can, there are various diagnoses which can have problem with the anesthesia, like Alagilles have cardiac issues, vascular issues, renal issues. Moyamoyas can be seen with Alagilles. Biliary atresia can have splenic malformations, complex heart disease, interrupted inferior vena cava. So that can be an issue while we anesthetizing the patient. And primary hypercholesterolemia, as you know, has some renal problems as well as cardiac dysfunctions. So these patients who are having all these diagnoses can have some anesthesia issues. So a proper screening is required. And while the PAC is done, all systems should be seen, vascular access should be defined, and the kind of diagnosis can have impact on the method of induction. The intraoperative fluid requirement can be a challenge. Drug dosing can be a challenge, because if you have kidney disorders, then you need to change the doses also. A ventilatory strategy might be different in different diagnoses, like cystic fibrosis will have a different ventilatory strategy, and others likewise will have different ventilatory strategies as the diagnosis goes on. Again, another very important part, as I've already discussed, is the immunization and the viral susceptibilities. The time of immunization is an important issue, because vaccines, once vaccines become less potent in cases in which the ESLD is there, or after the transplant, because after transplant immunosuppression is there, so the immunogenicity of vaccines becomes less. So as far as possible, as soon as possible, before the child goes into end-stage liver disease, the patient should be given the maximum coverage of the vaccines. In cases of biliary atresia, again, the humoral immunity is low for rubella, measles, and varicella vaccines, and the response is not really good. This has been shown in few studies. And as far as influenza infection is concerned, there has been cases in adults that influenza infection can cause hepatic decompensation. So giving influenza vaccine should be considered in all the patients. And as far as children are concerned, you can give influenza vaccine as soon as possible, as low as 6 months of age. And so So completion of vaccination should be done as fast as possible in a accelerated way, and influenza vaccine should be considered more than 6 months of age. And we should always be screening for EBV and CMV serologies because children are susceptible to these infections. If the patient, the child is seronegative and the the donor is seropositive, then there is likelihood that post-transplant the child might get the infection. And in children less than 1 year of age, we prophylactically give Valgal cyclovir to prevent these infections. Other issues are psychosocial issues because once we declare to the patient the diagnosis and the need for transplant, the mother first has the guilt of the disease, that the mother takes it on her, that it is because of her that the child got the disease. There is less acceptability, the denial phase goes on for long, and the anger, frustration comes into the family. And so all these issues needs to be addressed. A clinical psychologist, a psychiatrist plays a vital role in assessing all this and understanding the condition of the family. And if there is a issue that the child's protection is at stake, then the government should get into the system and get engaged with protecting the child against these social issues. There can be some non-adherence issues, like children who have a history of resistance in taking the medicines can have non-adherence. Likewise, there is substance abuse in teenage that can have an issue. Physical or sexual abuse can be an issue for non-adherence. School abstinence also indicates that probably the child might have some non-adherence to the medicines in future. And single parent can again be an indicator that probably the medicine might not go well for a long term, and there might be non-adherence to the immunosuppression medicines. Neurocognitive and neurodevelopmental assessment also should be done because pure cognitive functions is seen with poorer weight and poorer nutrition, and those children who have low head circumference. And it has been also seen that low vitamin E levels also indicates poorer neurocognitive outcomes. And also, there are a study in which bilirubin level pre-transplant in biliary atresia was the leading factor in poor cognitive function in the future. But that is also a controversial thing. In children with biliary atresia, what we have found is that the fine motor and the visual problem solving and the receptive language development is normal, but gross motor and expressive language development is the weakness in them, and females are more vulnerable to having this. So children with biliary atresia are likely to have some sort of neurocognitive, neurodevelopmental issues post-transplant also, especially the females. And the age of Kasai correlates inversely to the receptive language performance. The later the Kasai is done, the neurocognitive issues might be more. So proper assessment and a quick neurocognitive testing should be done, early intervention should be done, and an aggressive nutritional management should be done because nutrition plays a big role in the outcome of the neurocognitive issues in these children. So to conclude, I would say pre-transplant assessment actually takes a lot of effort and a lot of people are involved. We would need the help of a dentist, we would need a psychiatrist, psychologist, a dietitian, pediatric hepatologist, pediatric gastroenterologist, even the general pediatrician, vaccination. So there are so many things that we need to address before transplant. So we need a good support of the whole team as a group to get a good result. Thank you very much.